Welcome back to the deep dive. Our mission, as always, is taking these huge stacks of, well, really dense medical sources today, focused on the clinical essentials for mastering breast and gynecological health and boiling them down, getting you that core framework you need for really elite understanding. We're definitely going beyond just the basics here, looking at those critical connections, the precise protocols. It's a complex area.
It really is. And this dive is all about that integration, clinically speaking. The sources we're using are strong because they don't treat these as separate systems. They look at the female endocrine system as, one interconnected unit.
Right.
We're not just talking isolated organs. It's about analyzing how hormonal signals, symptoms like pain or discharge, even pathology, how it all constantly links back and forth between the breast and the reproductive system.
And you see that importance immediately when you look at the mandates for assessment. The breast exam, it's not optional, is it? It's absolutely essential in a GYN context.
Absolutely not optional. It's mandated. The need for a systematic breast exam comes up in several specific situations that might not seem immediately obvious. Well, think about a woman presenting with what seems like an ovarian tumor. A breast exam is mandatory then because you have to rule out the possibility that the ovarian issue isn't primary at all. It could actually be a metastasis originating from the breast.
Wow, okay. That really drives home the shared pathology. And the connection goes even deeper with diagnostics, right? Especially around infertility.
Yeah, definitely. If a woman's undergoing an infertility workup and she presents with galactorrhea, any kind of nipple discharge, that's a huge red flag. It points you immediately towards investigating hyperprolactinemia.
And treating that underlying hormonal cause might actually resolve the infertility itself.
Often does. And this hormonal thread, it runs through the whole reproductive life cycle, really, even in diagnosing something like primary amenorrhea. Well, if the patient has poorly developed breasts, your clinical suspicion immediately shifts. You're thinking a central cause, something systemic. Maybe the hypothalamic pituitary axis isn't firing right.
Yeah.
But conversely, if she has well-developed secondary sex characteristics, the hormonal signals are clearly there, so the amenorrhea is much more likely a local issue, maybe anatomical, within the genital tract itself.
It's like reading the body signals. And one more mandate we absolutely have to stress before we get into the weeds. HRT, hormone replacement therapy.
Oh, absolutely non-negotiable.
Regular breast exams are a clinical imperative for any woman on HRT. It has to be built right into the management plan.
It's just part of the deal, the cost of entry, if you like, for prescribing those hormones.
Okay, good. So let's unpatching this. We'll begin with the foundations. The hormonal context, development, and then touch on acute conditions like infections.
Right. The absolute foundation here is just how incredibly sensitive breast tissue is. We're talking about all of it, the glandular parts, the ducts, the surrounding stroma. It's all intensely reactive to ovarian hormones.
Throughout life.
Throughout the reproductive years, definitely. But it even persists well after menopause. That sensitivity doesn't just switch off.
So the breast is essentially acting like an endocrine barometer. Any hormonal shift, natural or maybe medication-induced, shows up in the breast tissue.
That's a great way to put it, a barometer.
Precisely.
Yeah, and that sensitivity, well, that's the clinical reason why excess ovarian hormones or even certain anti-hormones we'll get into later are such major drivers, often causal factors in a lot of breast diseases, both benign and malignant. The tissue is just constantly listening to that hormonal environment.
Makes sense. Okay, so moving from that function to structure development, the sources talk about congenital issues we need to be aware of, things like absent or extra nipples.
Yeah, the whole range. Absent or extra nipples, sometimes even supernumerary breasts, extra breast tissue, and also underdevelopment, aplasia or hypoplasia, which can sometimes just affect one side, be unilateral.
And you mentioned this links back to hormone therapy sometimes.
It does, yeah. In cases where there's significant underdevelopment, like in Turner syndrome, or certain types of primary amenorrhea where breast development just hasn't happened properly, estrogen therapy becomes crucial. It serves two key purposes.
Okay.
One, yes, it helps stimulate the expected breast development. But just as importantly, maybe even more so long term, it significantly reduces the patient's risk of developing severe osteoporosis later on.
Ah, right, because of the bone density connection.
Exactly. It's not just cosmetic. It's actually a hormonal necessity for maintaining skeletal health down the line.
That's a really important link to make breast development and future bone health. Okay, let's pivot then to acute stuff. Infections, inflammation. The sources say this is mainly an issue for breastfeeding women, right? In the puerperal period.
That's where you see it most often, yes. In that acute setting, management really comes down to quick, accurate diagnosis. You start simple cracked nipples, easily managed with topical creams, like mass cream.
Okay.
The real challenge starts if it progresses to mastitis, actual inflammation of the breast tissue.
And the standard approach for that. It's conservative initially.
It is usually a three-pronged approach. Supportive care, really. Analgesics for the pain and any fever. Hot fomentation, basically applying heat packs to help with drainage and blood flow. And of course, a proper course of antibiotics to tackle the underlying infection, which is often Staph aureus. The goal is conservative management, trying to stop it getting worse.
But what if that doesn't work? Or it's caught too late and it forms an abscess, a localized pocket of pus?
That's the critical turning point. Management shifts completely then. You can't treat a localized abscess conservatively. It always needs surgical intervention. Always. Specifically, incision and drainage. That distinction has to be absolutely clear in your mind. General inflammation, mastitis, conservative approach.
Yeah.
Localized collection of pus. An abscess, you have to drain it surgically.
Got it. Absolutely clear distinction. And that clarity actually leads us nicely into maybe the most common and often really frustrating breast complaint. Mastalgia. Breast pain.
Ah, yes.
This is where the sources give us a ton of detail, especially on the drug options and their trade-offs. Hashtag tag 2. Deep dive into mastalgia, breast pain, and its management.
Yeah, mastalgia. The very first step always is careful categorization. Because the type of pain fundamentally dictates how you investigate and what treatments you consider.
So the main split is cyclical versus acyclical.
Exactly. Cyclical pain is, well, typically seen in younger women. It's clearly tied to the menstrual cycle, usually flares up for a few days just before the period starts. Acyclical pain, though, isn't linked to the cycle. It tends to be more common in older women. And that distinction is vital because if an older woman presents with acyclical pain, your investigation immediately broadens. You have to start thinking about ruling out more serious underlying pathology.
Because it could be a symptom of breast cancer in that group.
It could be, yes. Needs thorough investigation. We also need to define how severe the pain is. Clinically, we talk about severe mastalgia if it lasts more than, say, 7 days, if it's bad enough to need drugs, and if it's actually interfering with her daily life, work activities. And then there's chronic mastalgia. That's pain that's been going on for more than 6 months. And again, that duration absolutely triggers a need for formal investigation to rule out anything sinister.
Okay, so once you've categorized it, cyclical, cyclochronic choronobysis, let's walk through the treatment options, focusing less on memorizing exact doses maybe, and more on those crucial trade-offs. Efficacy versus side effects versus cost versus just how likely someone is to actually take the medication.
Good approach. The foundation, the first line, is usually NSAIDs, your standard non-steroidal anti-inflammatories for pain relief. Simple analgesia.
Okay.
Beyond that, we get into supplements. And the data really points quite strongly towards evening primrose oil here.
That seems to have a pretty high success rate according to the sources.
It really does. It's given as a capsule, contains gamma-linoleic acid or gamma-linic acid. The dose is typically 3 grams a day, and the sources report significant relief, around 70% success rate.
Which is impressive.
Very. And clinically, it's often a good starting point because the side effects are usually minimal. Maybe some occasional mild nausea or a bit of a headache, but generally well tolerated. Contrast that with something like vitamin B6 sometimes mentioned, but the evidence suggests it benefits very few women. Low overall efficacy.
Okay, so evening primrose oil sets a high bar. Now, the hormonal and anti-hormonal options, this is where it gets tricky, right? The conflict between does it work and can the patient actually tolerate it?
Exactly where the trade-offs become really sharp. Let's start with danazol.
High efficacy.
Matches evening primrose oil, actually. Around 70% success rate reported at a dose of 100 milligrams twice a day. But, and that's a big but, danazol is an androgenic steroid. Meaning it comes with potentially severe androgenic side effects. Things like weight gain, maybe voice deepening, acne, unwanted hair growth. These can be really bothersome.
Right.
That, plus the fact that it tends to be quite expensive, severely limits how long people can stay on it. Compliance drops off. So it's a powerful drug, yes, but many patients just can't tolerate it beyond the short term.
Okay. Next category, dopamine agonists like bromocriptine.
Right. Bromocriptine, usually 2.5 milligrams twice a day. The success rate here is lower, maybe around 45%. And again, compliance is a major issue, but for different reasons.
What kind of side effects?
Mostly gastrointestinal and neurological. Significant nausea, sometimes vomiting, feeling dizzy or giddy, it can be quite unpleasant. Poor compliance is just a recurring theme with these potent hormonal drugs.
Is there an alternative here?
Yes, and it's clinically important. The sources mention cabergoline, brand name Destinex. It's a longer-acting alternative, taken maybe 0.25 milligrams twice a week. It works similarly, but generally has significantly fewer side effects, making it a much better tolerated option for many.
Okay. Now, tamoxifen. We usually think of that in the context of breast cancer treatment or prevention. Using it for benign pain seems counterintuitive.
It does, but it's sometimes considered, usually at a low dose, like 10 milligram daily. The rationale is that it's often better tolerated in the short term compared to danazol or bromocriptine. Fewer immediate, bothersome side effects for some women.
But the long-term risks.
That's the crucial trade-off. The long-term risk profile is serious and needs careful monitoring. It significantly increases the risk of endometrial hyperplasia.
Thickening of the uterine lining.
Exactly. And although it's rare, it has been linked to actual endometrial cancer. So using a drug developed for cancer to treat benign pain, well, it requires a very careful risk-benefit discussion with the patient. Its routine use for simple mastalgia is highly limited because of those potential long-term dangers.
Makes sense. Okay, what if the pain is really severe, resistant to other treatments? Could you potentially use something like a GnRH analog? Induce a temporary menopause, essentially.
You could, yes. Gonadotropin-releasing hormone analogs, like goserelin, often given as a monthly injection, 3.6 milligrams, they are highly effective because they basically shut down ovarian hormone production completely. No estrogen, no cyclical hormonal influence.
But the downsides must be significant.
Huge. Firstly, they are extremely expensive. Secondly, they obviously induce amenorrhea stop periods altogether. And thirdly, and perhaps most worryingly, long-term prolonged use carries a major risk of osteoporosis, because you're taking away all that bone-protective estrogen.
All right.
So goserelin is really reserved for very severe refractory cases, used only for short-term therapy, maybe a few months, when absolutely everything else has failed. The cost and the bone health risks are major limiting factors.
And testosterone. Is that ever used?
Testosterone undecanoate, brand name Restindol, 40 milligrams twice daily. It can be effective, yes. But, similar to danazol, the limiting factor is the androgenic side effects. The sources note these typically start becoming problematic after about 3 months of continuous use, often forcing women to stop the therapy.
So, lots of options, but lots of caveats. Is there anything specific for just that premenstrual type of mastalgia?
Yes, there is. Toromifene. It's a SERM, a selective estrogen receptor modulator.
Like tamoxifen, but different.
Similar class, but used differently here. Toromifene, 60 milligrams daily, is prescribed specifically and only during the luteal phase of the cycle, a second half, after ovulation leading up to the period.
Targeted timing.
Exactly. That restricted dosing helps limit exposure. It's shown to improve mastalgia in about 60% of cases, and crucially, it seems to have fewer side effects compared to tamoxifen when used this way. So it's often a preferable choice for clearly cyclical, premenstrual specific pain.
Okay. Now, circling back to the non-cyclical pain, especially in older women, you said the priority is ruling out malignancy. But sometimes the pain isn't actually coming from the breast tissue itself.
That's absolutely right. A really important differential diagnosis to consider is chest wall pain, musculoskeletal pain, often diagnosed as Tietze syndrome, which is inflammation of the cartilage connecting the ribs to the breastbone.
How do you manage that?
Often, simple NSAIDs provide relief, but if that's not enough, or to confirm the diagnosis, a local injection can be very effective. A mixture of a local anesthetic and a steroid injected right into the tender area. The sources mention a good response rate, around 75% relief with this. It's a crucial step to make sure you're not missing a musculoskeletal cause and treating it inappropriately as breast pain. Tag 3, benign lumps, cysts, and discharge.
Okay, let's shift gears to physical findings. Lumps, discharge. Things that understandably cause a lot of anxiety for patients. What's the baseline statistic we should keep in mind?
The reassuring starting point the number of clinicians rely on is that less than 10% of all breast lumps that present clinically turn out to be malignant. The vast majority are benign.
Okay, less than 10%.
However, because that risk is not zero, the clinical mandate is absolute. Every single lump requires systematic examination and thorough investigation, no exceptions.
And even if it seems benign initially, if it's causing symptoms?
Yes. If a lump is symptomatic, meaning it's painful or it's noticeably growing, then surgery is generally required. Regardless of the initial suspicion being benign, symptoms trigger action.
All right. Let's start with cystic swellings. Fluid-filled lumps. The sources differentiate single versus multiple cysts.
They do. Single cysts are very often benign, simple cysts. Multiple cysts, however, are viewed with a bit more caution as they carry a slightly higher theoretical possibility of future malignant change developing within that complex cystic environment.
And the diagnostic approach here relies on that triad.
The essential diagnostic triad, yes. That's fine needle aspiration cytology, FNAC, to examine the cells, mammography for imaging, and ultrasound, which is particularly good at confirming the cystic nature.
And treatment. Is simple draining usually enough?
For young women with a simple single cyst, yes, simple aspiration of the fluid is often sufficient treatment. Drain it, it collapses, problem solved. But there are 3 absolute non-negotiable rules that mean aspiration isn't enough and surgical treatment becomes necessary.
Okay, what are those rules?
Rule 1, if the fluid you aspirate is bloodstained, that's always a red flag. Rule 2, if the cyst comes back, recurs after you've already successfully aspirated it once. And Rule 3, if the patient presents with multiple cysts that aren't resolving or are causing ongoing issues. Any of those 3 means surgery is typically the next step.
Got it. Blood, recurrence, or multiple cysts. Okay, moving on to fibroadenomas. You said these are the most common benign tumor.
By far. Fibroadenomas can pop up at pretty much any age. They're usually single, they rarely get very large, typically stay under 5 centimeters. And they account for roughly 15% of all breast tumors found.
And the key factor influencing management isn't just the lump itself, but the patient's age.
Exactly. Age is the critical determinant here, dictating the level of risk tolerance and the recommended approach.
So let's focus on that cutoff. The sources mention age 30 as being pivotal. What's the difference in approach before and after 30?
Before the age of 30, if your investigation's the imaging, maybe FNAC have rigorously confirmed that the fibroadenoma looks entirely benign, it's generally considered safe to just observe it. Monitor it, but avoid potentially unnecessary surgery.
Unless it becomes symptomatic.
Right. Even in a younger woman, if that known fibroadenoma starts to become tender or shows clear signs of increasing in size, then surgical removal is still warranted. Symptoms override the age rule.
Okay, and after age 30?
After age 30, the approach changes. Because the background risk of malignancy, even within what looks like a fibroadenoma, increases slightly with age, even if it's still a small risk, the universal recommendation is for excision biopsy for all fibroadenomas found in women over 30.
Just to be absolutely sure with histology.
Precisely. You want that definitive tissue diagnosis. It's also interesting, just connecting back to our mastalgia discussion, that fibroadenomas in younger women have been shown to sometimes respond hormonally. They can shrink with danazol therapy.
Interesting link. Okay, now for the symptom that probably causes the most immediate alarm. Nipple discharge. Especially if it's blood-stained.
Yeah, blood-stained discharge understandably causes significant concern. The good news is that most commonly it's due to benign conditions. The top culprits are usually a ductal papilloma, which is a small growth within a milk duct, or periductal mastitis, inflammation around the ducts. Malignancy can cause it, but it's actually relatively rare as the primary cause of bloody discharge.
But the diagnostic challenge here is?
The challenge is that standard tools, like cytology, looking at cells from the discharge, or even mammography, are often insufficient. They might not pick up a tiny papilloma or rule out an early malignancy definitively.
So what's the recommended approach then?
Because of that diagnostic uncertainty, the standard recommendation for persistent, unexplained blood-stained nipple discharge is often surgical, resection of the affected duct or lobe to get a definitive diagnosis and treatment.
And specifically on that ductal papilloma, it's benign, but you still remove it. Why the aggression?
It is typically benign, yes. Diagnosis might involve ductoscopy, looking inside the duct with a tiny scope, but ultimately, excision is recommended. The reason is that while it's benign now, the sources confirm that duct papillomas do carry a small but definite potential to undergo malignant transformation over time. So proactive removal is considered the safer long-term strategy.
Okay, makes sense. Let's shift from bloody discharge to galactorrhea, that milky discharge, often linked to hormonal issues. The definition involves hyperlactin.
Yes, the clinical threshold is usually a serum prolactin level greater than 25 nanograms per milliliter. Although it's important to remember, not every woman with high prolactin will actually have noticeable galactorrhea. Some are asymptomatic.
And the main causes we look for?
Primarily, it's either hyperprolactinemia itself, the high prolactin level, maybe idiopathic or drug-induced, or, more concerningly, the presence of a pituitary adenoma. a tumor on the pituitary gland.
And the worry with the pituitary tumor is size.
Particularly if it's a macroadenoma, a larger one. Because the pituitary sits right near the optic nerves, a large adenoma can press on them, potentially causing visual field problems. Clinically, galactorrhea is often a flag that goes along with other hormonal disruptions like amenorrhea, no periods, oligomenorrhea, infrequent periods, and resulting infertility because high prolactin interferes with the normal reproductive hormone cycle.
But it's not always a pituitary issue, right? What else needs to be ruled out?
Absolutely. You need a thorough workup. Check for underlying hypothyroidism. That's a common one. Consider recent chest wall injury or even something like herpes zoster, shingles, affecting the chest nerves. Chronic stress can sometimes elevate prolactin. And, crucially, you have to take a detailed medication history.
Which drugs are key culprits?
Many can do it, but you particularly need to ask about estrogens and, very importantly, dopamine receptor blocking agents. Lots of medications, including some psychiatric drugs and anti-nausea meds, work this way and can cause prolactin levels to rise and lead to galactorrhea.
Okay. Let's touch on periductal mastitis. You mentioned it earlier with bloody discharge, but it's often seen in older women, can cause retracted nipples, and has this strange but strong link to smoking.
Yes, it's a distinct entity, often presents with discharge, maybe nipple retraction, and the soaking link is robust, even if the exact why isn't perfectly clear. There are two main theories. Theory 1. Smoking alters the bacterial environment within the ducts. Maybe it encourages the growth of less common pathogens like E. coli or anaerobic bacteria. Theory 2. It's a direct toxic effect. Components in tobacco smoke directly damage the lining, the epithelium, or the tiny blood vessels supplying the ducts.
So how does that affect treatment?
Well, if it's primarily bacterial, theory 1, then long-term appropriate antibiotics combined with surgical excision of the chronically inflamed duct tissue is the mainstay. But if it's direct toxicity, theory 2, then the absolute key to preventing recurrence is smoking cessation. Realistically, the current standard approach usually involves both antibiotics and excision of the affected area, plus strong advice to quit smoking.
Before we move into cancer specifically, we have to address this progestogen paradox, as the sources mentioned. It sounds important for understanding hormonal risk.
It's absolutely vital, yeah. A really fascinating clinical nuance. The paradox is this. We see evidence that the progestogen-only pill, the mini pill, actually reduces the incidence of certain benign breast diseases. Things like fibrocystic changes, maybe some types of cysts. The reduction is significant, maybe 35% to 40%.
Okay, so that sounds like a benefit. Where's the paradox?
The paradox is that despite reducing benign disease, the same progestogen exposure seems to simultaneously increase the lifetime risk of developing actual breast cancer, especially noted in older women using it long-term.
Wow. Why would it do both? Reduce benign issues but increase cancer risk.
It strongly suggests a differential effect on breast tissue receptors. The thinking is that progestogens might have some kind of inhibitory or stabilizing effect on the pathways that lead to benign proliferation, things like cysts or fibroadenomas. But at the same time, they might actually fuel or promote the growth and progression of existing, perhaps subclinical malignant cells that happen to be sensitive to progestin stimulation.
So different effects on different cell types or pathways.
Potentially, yes. It makes the decision to use progestogen-only contraception, especially long-term in older women, a really complex risk-benefit calculation that needs careful consideration. Okay, let's shift focus now directly to breast cancer. It's the most common cancer in women worldwide and accounts for about 10% of all the breast problems presenting in a clinical setting. We need to meticulously go through the risk factors, starting with genetics and family history.
Right. A strong family history, first or second-degree relatives, mother, sister, daughter, that's always a major flag. How significant is the specific genetic component, like BRCA?
The most widely known mutations, BRCA1 and BRCA2, are actually found in a relatively small percentage of all breast cancer cases, overall maybe 3% to 8%. But if a woman does carry one of these mutations, her individual risk is dramatically increased. It signals a very high familial risk and absolutely mandates much more intensive screening protocols, which we'll detail later.
And let's quickly reiterate that connection to GYN cancers we mentioned at the start, the shared risk.
Crucial reminder for clinical practice. A woman diagnosed with ovarian cancer is at a significantly higher risk of subsequently developing breast cancer, and vice versa. They seem to share some underlying etiological pathways, maybe common genetic predispositions or hormonal influences.
So a diagnosis of one necessitates screening for the other.
Absolutely. If you diagnose an ovarian tumor,
Huh.
you must thoroughly screen the breasts because it could be a metastasis from an undetected primary breast cancer. And if you diagnose breast cancer, screening the ovaries, often with ultrasound, is also part of the standard workup.
Okay. Now, age. You mentioned this earlier, but it's probably the single biggest non-modifiable risk factor. The stats are quite stark.
They really are, and they demand different levels of clinical vigilance.
Yeah.
In women of childbearing age, let's say under 40 or 45, about 15% of breast lumps turn out to be malignant.
Okay.
Contrast that sharply with women over the age of 60. In that age group, a staggering 50% half of all presenting breast lumps prove to be malignant.
50%. Wow.
Yeah. That huge age-dependent difference in prevalence fundamentally dictates how aggressively and urgently you investigate any new lump found in an older patient. The index of suspicion has to be much higher.
Okay. Let's talk hormones again, but endogenous ones, this time the body's own hormones. The theme seems to be about duration of exposure.
Exactly right. A major component of risk is linked to the total cumulative lifetime exposure to estrogen. Factors that increase this exposure duration include early menarche, starting periods young, late menopause, stopping periods late, having a higher total number of menstrual cycles throughout life, or even having naturally shorter cycles. All these essentially mean the breast tissue is exposed to estrogen's proliferative effects for a longer period.
And it's not just estrogen anymore.
Correct. While estrogen has long been recognized as the classic hormonal driver, the sources emphasize that more recent evidence strongly implicates progestogens as also being carcinogenic, contributing to breast cancer risk. It's exposure to both hormone types that matters.
What about reproductive factors? Having children, breastfeeding?
Key factors here. Nulliparity, meaning never having given birth, increases risk. Having the first full-term pregnancy relatively late in life, specifically after the age of 30, is also associated with higher risk compared to earlier first pregnancies. And choosing not to breastfeed, or being unable to, is also considered a risk factor. Lactation seems to have a protective effect.
Okay. And lifestyle factors, things patients can potentially modify.
Obesity is a big one. It significantly increases risk, particularly after menopause. The main mechanism is thought to be peripheral conversion. Adipose tissue, body fat, converts precursor hormones, androgens, into estrogen, thereby increasing the total circulating estrogen load the breast tissue sees.
Yeah.
Smoking and alcohol consumption also contribute. Smoking, as we discussed with periductal mastitis, might encourage atypical cell growth or suppress the local immune system, making it harder for the body to eliminate abnormal cells. Alcohol's mechanisms are complex but consistently linked to increased risk.
Okay, let's tackle exogenous hormones, now the ones taken as medication. OCPs, oral contraceptive pills, and HRT. Are there specific high-risk scenarios for OCPs?
Yes, the risk isn't uniform across all types or users. The sources suggest the highest risk profile seems to be associated with combined oral contraceptives, COCs, that contain a high-potency progestogen, especially when they are used for a long duration, defined as more than 4 years, and crucially, when that use occurs in a very young woman, specifically under the age of 25, before she has had her first full-term pregnancy.
That's a very specific combination of factors.
It is, and in that particular scenario, some studies suggest a potential 2 to 5-fold increase in lifetime breast cancer risk. It highlights the importance of the progestogen component and the timing of exposure relative to pregnancy.
That's critical info for counseling young women. Does that elevated risk persist forever after stopping the pill?
Fortunately, no. The evidence suggests that the risk does decrease significantly over time after stopping COCs, generally returning close to baseline levels about 10 years after cessation. An important point the sources make is that the focus on risk is increasingly shifting towards the progestogen component in COCs, perhaps even more so than the estrogen.
Interesting. Okay. And for hormone replacement therapy, HRT, used for menopause symptoms, what's the critical duration limit?
The strong recommendation is that HRT should not be administered continuously for more than 10 years due to the increased risk of breast cancer with longer duration use. And as we said before, women on HRT absolutely require regular screening, typically mammography every 1 to 2 years, as part of their ongoing management.
Is there any upside if cancer is diagnosed in an HRT user?
There seems to be, yes. An interesting clinical observation is that breast cancers diagnosed in women who have been using HRT tend, on average, to have a somewhat lower malignant potential. They're often lower grade or earlier stage, and consequently, they tend to carry a slightly better overall prognosis compared to cancers that arise sporadically in non-HRT users.
Okay. Shifting now to how breast cancer actually presents, what does a clinician typically find or look for during an examination?
The most common first symptom, the thing that usually brings the woman in, is feeling a lump. Pain and nipple discharge are possible, but tend to occur later in the disease process. Clinically, a malignant lump often feels firm, it has irregular borders or edges, and in more advanced stages, it can become fixed, tethered to the underlying chest wall muscles or fascia so it doesn't move freely.
And lymph nodes.
Palpable axillary lymph nodes and large nodes in the armpit are typically a sign of more advanced disease where the cancer has started to spread regionally. And the absolute rule during the exam is always palpate the other breast as well for comparison and to check for any bilateral issues.
This relies heavily on the skill of palpation. How accurate is a clinical breast exam by itself? Does age play a role here too?
Accuracy is definitely variable and heavily age-dependent. In younger women, say under 40, clinical palpation alone can miss up to 50% of cancers. That's largely because the breast tissue is often very dense and glandular, making it hard to feel small or deep lumps.
But it gets better with age.
Significantly better. Accuracy improves to around 80% in women aged 40 to 49 and climbs to about 95% accuracy in women over 60, where the breast tissue is typically less dense, more fatty replaced.
So because palpation isn't perfect, especially in younger women.
Exactly. That variable accuracy is a major reason why breast self-examination, while debated in terms of mortality benefit, remains important for promoting early presentation. If a woman feels something new or different, regardless of her age or recent clinical exam, she needs to bring it to medical attention promptly. Early detection is key.
Okay, that leads us directly into imaging. Let's start with the workhorse. Mammography. Who needs it, and what are its main limitations, especially in those younger women?
Mammography is the standard imaging tool. It's indicated for pretty much all older women presenting with a lump, any woman considered high risk due to family history or genetics, sometimes for women with significant cancer phobia needing reassurance, and it's mandatory as a baseline before starting HRT.
And for screening the general population.
Screening guidelines generally suggest it's most cost-effective for women aged 45 or 50 up to about 60 or 74, typically performed every 1 to 2 years. The standard procedure involves 2 views of each breast, the mediolateral oblique MLO view and the craniocaudal C view.
But you mentioned it's unreliable under 40. Why is that?
It's unreliable in about 50% of women under 40, primarily because their breast tissue is naturally dense and glandular. On a mammogram, both dense tissue and cancers can appear white, making it very difficult to distinguish a small tumor hiding within that dense background. It's like trying to find a snowball in a snowstorm.
Okay, other limitations.
It's strictly contraindicated during pregnancy because of the radiation exposure to the fetus. And interpretation can sometimes be tricky if there's been previous breast surgery, which leaves scarring, or if the woman is currently on HRT, which can also increase breast density temporarily.
But despite these limitations, it saves lives.
Absolutely. Large studies have consistently shown that regular mammographic screening significantly reduces breast cancer mortality by around 30%. It's still our best population screening tool. Now, what are we actually looking for on the mammogram images? Key signs include any alteration in the normal tissue density pattern, maybe skin thickening over an area, fibrous streaks radiating from a point, or changes in the nipple's appearance or position. But the finding we most urgently look for, the real hallmark of potential early, often non-palpable cancer, is microcalcification, tiny specks of calcium.
Microcalcification, got it. Okay, that brings us to ultrasound. Often used alongside mammography, but it has specific strengths and weaknesses, right? Especially useful in younger women.
Exactly. Ultrasound, usually done with a high-frequency probe around 10 megahertz, is essential across all age groups, but it's particularly valuable in women under 35 or those with dense breasts where mammography struggles. Its biggest strength is differentiating fluid-filled cystic lumps from solid lumps. It's excellent for that.
But its major limitation.
Its major limitation is that it generally fails to identify microcalcification. It's just not good at picking up those tiny calcium specks that mammography excels at finding. So the 2 tests are often complementary. And connecting back again, ultrasound is also the tool used for screening the ovaries, which is often required as part of the breast cancer investigation workup.
Okay. Finally, advanced diagnostics. MRI and FNAC, fine needle aspiration cytology. Where do they fit in?
MRI, magnetic resonance imaging, offers incredibly detailed images. Its main roles are providing the most accurate measurement of the actual size of an invasive tumor, which is crucial for surgical planning and staging. It's also very helpful in assessing the extent of disease, checking for multiple tumor sites, and sometimes predicting how well a tumor might respond to chemotherapy. It's particularly useful in high-risk screening in young women with dense breasts or after surgery where scar tissue can make other imaging difficult.
And FNAC, getting cells for analysis.
FNAC involves using a thin needle to draw out cells directly from the lump. It's highly specific for diagnosing malignancy. Accuracy is typically 90% to 95% when done well and interpreted by an experienced cytopathologist. It gives you cellular information quickly.
Now, critically, there's a specific order you need to do these in, right? Imaging before aspiration.
Yes, this is a vital practical point. Imaging, whether it's mammography or ultrasound, must always be performed before the FNAC procedure.
Why is that sequence so important?
Because the process of sticking a needle into the lump for FNAC inevitably causes a small amount of bleeding and bruising, a hematoma within the tissue. If you do the FNAC first, that subsequent hematoma can completely obscure the area on later imaging, potentially masking the actual lesion or making the images very difficult, even impossible to interpret accurately. So image first, then aspirate.
Hits first, then aspirate. Got it. So after deploying this whole arsenal, the clinical exam, mammography, ultrasound, FNAC, what's the overall diagnostic power? How confident can we be?
When all these tools are used together, systematically and interpreted correctly, the combined diagnostic accuracy is incredibly high. The sources state it identifies cancer in about 99.5% of cases. That level of certainty, that near-perfect diagnostic power, is really the standard of care we aim for. It's a mastery this deep dive is about. #V screening, treatment protocols, and prognosis.
Okay, we've got the diagnosis down. Now let's solidify the screening guidelines and the treatment pathways. Let's start with the official recommendations like from ACOGAS for women who are considered average risk.
Right. For average risk women, the general guidance is no routine screening recommended under the age of 40, simply because the incidence is relatively low.
Okay.
For women aged 40 to 49, it's more of a discussion. Screening mammography every 2 years is presented as an option they can choose to start, based on individual values and risk tolerance after talking with their doctor.
And the main screening window.
The core group for routine screening is typically women aged 50 to 74. For them, standard mammography every 2 years is the recommendation.
What about older women, 75 and up?
Over 74 or 75, the recommendation becomes more conditional. Screening is generally continued only if the woman is in good health and her overall life expectancy is projected to be more than 10 years. The potential benefits need to outweigh the potential harms or burdens of screening at that age.
Okay, that's average risk. Now, the protocol shifts dramatically for women identified as high risk, right? Those with BRCA mutations, strong family history, or a calculated lifetime risk over 20%.
Dramatically is the right word. For this specific high-risk group, the screening becomes much more intensive, much more aggressive. The standard protocol mandates clinical breast exams more frequently, typically twice a year. Annual mammography is still crucial, but critically, it's supplemented with annual breast MRI as well.
The addition of MRI every year.
Because MRI is generally more sensitive than mammography, especially in younger women or those with dense breasts, which includes many BRCA carriers. It's better at picking up small cancers that mammography might miss in this high-risk population. The goal is the earliest possible detection.
And there's another specific high-risk group. Women who had radiation therapy to the chest area when they were younger, maybe for treating Hodgkin's lymphoma.
Yes, that prior thoracic radiation significantly increases breast cancer risk later in life. There's a specific protocol for them, too. Screening needs to start much earlier, typically beginning 8 to 10 years after the radiation treatment was completed, or by age 25, whichever comes first.
And what does that screening involve?
It involves annual mammography plus annual breast MRI, similar to the BRCA group, and clinical breast exams every 6 to 12 months. It's another intensive surveillance strategy tailored to their specific elevated risk.
Okay, let's move into treatment itself. Surgery is usually the first step. The sources mention options ranging from lumpectomy up to mastectomy. What's the key finding regarding outcomes?
The really pivotal finding, which fundamentally changed surgical practice over the last few decades, is that for many women with early-stage breast cancer, lumpectomy, which is breast-conserving surgery, just removing the tumor and a margin of normal tissue when combined with radiation therapy, yields survival outcomes that are comparable to having a full radical mastectomy.
So less invasive surgery can be just as effective long-term.
In many cases, yes. This discovery was huge, allowing for much less disfiguring surgical options without compromising survival. Of course, the decision is complex and depends on tumor size, location, patient preference, etc. Removal of axillary lymph nodes for staging is still done, but it's often more limited now, like sentinel node biopsy, unless the cancer has clearly spread to the nodes.
After surgery, adjuvant therapy aims to kill any remaining microscopic cancer cells and prevent recurrence. Let's talk about chemotherapy first. What are the general types of regimens used?
Adjuvant chemotherapy is proven to reduce the risk of recurrence by about 30%, which is substantial. The specific regimens vary, but many are based on anthracyclines. Common examples mentioned include maybe 4 cycles of adriamycin and cyclophosphamide, AC, or perhaps 6 cycles combining 5-fluorosil, 5-FU, adriamycin and cyclophosphamide, FAC or CAF, or similar regimens using epirubicin instead of adriamycin.
Are there newer additions improving outcomes?
Yes, a key clinical advance highlighted is the addition of taxane drugs like paclitaxel or docetaxel to these anthracycline-based regimens. Adding a taxane has been shown to further improve overall survival rates.
These are powerful drugs. Any specific precautions?
Absolutely. Because these chemotherapy drugs are potent and can be teratogenic, harmful to a developing fetus, women are strongly advised not to conceive during treatment, and for a significant period afterwards, the sources suggest avoiding pregnancy for at least 2 years after completing chemotherapy.
Okay. Beyond chemo, there's hormonal therapy, used long-term as prophylaxis, often for 5 years.
Yes, for hormone receptor-positive breast cancers, which most are, adjuvant hormonal therapy is critical. This typically involves taking a drug daily for 5 years, sometimes longer now. The main options mentioned are tamoxifen, usually 20 milligrams daily, or, particularly in postmenopausal women, an aromatase inhibitor like anastrozole, letrozole, or exemestane. Raloxifene, 60 milligrams daily, is also mentioned, often more in the prevention setting, but sometimes post-treatment.
And the benefit?
These hormonal therapies work by blocking the effects of estrogen on any remaining cancer cells. They've been shown to reduce the risk of the cancer coming back and also significantly reduce the risk of developing a new cancer in the opposite breast by as much as 50% over that 5-year period.
We talked about tamoxifan's risks earlier, endometrial issues. Any other cautions?
Yes, besides the endometrial hyperplasia cancer risk, tamoxifen is definitely teratogenic, so reliable contraception is essential for premenopausal women taking it. It also commonly causes menopausal-like side effects, particularly hot flashes and atrophic vaginitis, vaginal dryness.
Are the aromatase inhibitors like anastrozole better tolerated?
They have a different side effect profile. They don't carry the endometrial cancer risk or the blood clot risk associated with tamoxifen. However, they are known for causing musculoskeletal pain, joint stiffness, and importantly, they can worsen bone loss and increase fracture risk because they lower estrogen levels so profoundly. So bone health monitoring is crucial with AIs. Anastrozole is often cited at a dose of 192 milligrams daily.
So different risks and benefits to weigh. Okay, let's cover some special management circumstances. What about cancer survivors who then experience severe menopausal symptoms? Can they use HRT?
This is a very difficult area. The standard recommendation is that conventional HRT and combined oral contraceptives are strictly contraindicated after a breast cancer diagnosis. The concern is that giving exogenous estrogen, and often progestogen, could potentially fuel the growth of any dormant cancer cells.
So it's generally a no. What if the menopausal symptoms are truly debilitating?
If symptoms like severe hot flashes are drastically impacting quality of life, some experts might consider very low-dose, carefully selected hormonal therapy, but only under extremely close supervision and after extensive discussion of the potential risks versus benefits. It's highly individualized and generally avoided if possible. Non-hormonal treatments for symptoms are always preferred first.
What about raloxifene in this post-cancer context? You mentioned it earlier.
Raloxifene is interesting here. It's a SERM, like tamoxifen, but it acts differently in different tissues. It doesn't stimulate the endometrium, so no increased risk of uterine cancer. And it actually has a positive effect on bone density, helping prevent osteoporosis, unlike AIs. So it can be a safer option for managing bone health or potentially for some risk reduction in certain post-cancer scenarios.
But it still has risks.
Yes, the main one being an increased risk of venous thromboembolism blood clots, like DVT or PE. That risk needs to be monitored, just like with tamoxifen. And another point, lactation, breastfeeding, is also generally contraindicated after breast cancer treatment, partly due to concerns about hormonal shifts potentially stimulating recurrence in the treated or opposite breast.
Okay. Final complex scenario. What if breast cancer is diagnosed during pregnancy? That must be incredibly challenging.
It is one of Rue's most clinically and emotionally charged situations. The overall prognosis for breast cancer diagnosed during pregnancy or lactation tends to be somewhat worse than for non-pregnant women, possibly due to hormonal factors or maybe delays in diagnosis, or perhaps the generalized immunosuppression of pregnancy.
Can treatment proceed during pregnancy?
Surgery, like mastectomy or lumpectomy, and even radiation therapy can be performed during pregnancy. They are not strictly contraindicated, provided meticulous care is taken to shield the fetus from radiation exposure.
But chemotherapy?
That's the major issue. If postoperative chemotherapy is deemed necessary, which it often is, then it poses a significant risk to the fetus, especially during the first trimester, due to the high risk of birth defects, teratogenicity. Therefore, if chemo is required early in pregnancy, termination of the pregnancy is often medically necessary. If the diagnosis occurs later in pregnancy, sometimes chemotherapy can be delayed until after delivery, or specific agents might be chosen that are thought to be slightly safer in the second or third trimester, but it's always a high-risk situation requiring multidisciplinary care. #outtrack_outro. So we really synthesize everything we've covered to reach that level of mastery. I think the absolute core takeaway is the power of systematic assessment. Truly understanding that the combination clinical exam, mammography, ultrasound, and FNAC gives you that 99.5% diagnostic certainty. It means anything less than that full integrated approach just isn't complete. And alongside that is deeply understanding the nuances of hormonal risk and management. Knowing the strict guidelines, like the 10-year limit on HRT, or recognizing the specific danger of high-potency progestogens in young pre-pregnancy women, that knowledge is fundamental not just for diagnosis, but for prevention and counseling too.
Absolutely. And hopefully for you listening, you now have that much clearer, more comprehensive clinical framework. You can approach breast pathology thinking more like a clinician, understanding the complexities from the difficult trade-offs in managing something as common as benign breast pain, where even effective drugs like danazol often fail due to side effects, all the way to applying those highly sophisticated aggressive screening protocols needed for women at high risk due to genetics or prior radiation. It's about seeing the whole picture.
And maybe a final thought to leave you with. We talked quite a bit about raloxifene, particularly in the post-cancer setting. It's effective for risk reduction, it's safe for the endometrium, helps prevent osteoporosis, but it still carries that increased risk of thrombosis. For a woman who's already faced and survived a life-threatening cancer, making decisions involves constantly weighing these intricate benefit-risk trade-offs. How do you balance preventing recurrence against managing these secondary but still serious health risks like blood clots? What does this ongoing clinical tension really tell us about where personalized medicine is heading, where every single treatment choice has to be meticulously filtered through the lens of that individual patient's unique history, their specific constellation of risks, and the personal priorities? It's complex, and it's the future.